Section 1. Causes in the GI and hepatobiliary systems. Prepare your brain. We're doing rapid one-line recalls. All right, we're going to run this call and response style. I'll name the condition and you lock in the answer in your head. Ready? Acute appendicitis, fecalith, small bowel obstruction. The answer there is postoperative adhesions. Large bowel obstruction, colorectal carcinoma. Upper GI bleeding, think peptic ulcer disease. And finally, lower GI bleeding in adults, diverticulosis. Lock these associations in tight. They're literally the bread and butter of general surgery, and they get tested constantly. Now, what's really interesting here is how the etiology of a disease can totally flip just based on its acuity. For acute pancreatitis, the most common cause is gallstones. But if we shift to chronic pancreatitis, the culprit shifts entirely to alcohol. You know, exams absolutely love to test if you're paying attention to that single descriptive word, acute versus chronic. So keep this conceptual comparison etched in your mind. Let's keep that rapid-fire pacing going for hepatobiliary and surgical GI issues. Painless obstructive jaundice, immediately think carcinoma of the head of the pancreas. Acute cholecystitis, gallstones again. Ascending cholangitis, choledocholithiasis. Now, I really want to highlight something crucial for these next two. Often, our own medical interventions are the cause. The most common cause of an esophageal perforation, iatrogenic injury. And the most common cause of an enterocutaneous fistula, surgery itself. Moving right along to Section 2, causes in urology and others. Keep your momentum up here, because these are notorious for tricking people. Notice the massive recurring themes we've got going on here. Benign prostatic hyperplasia, or BPH, completely dominates two major clinical scenarios. It's the most common cause of acute urinary retention in the elderly male, and it's also the most common cause of obstructive uropathy in that exact same demographic. Next, painless hematuria and the elderly points straight to renal cell carcinoma. And hey, check out the stones. Calcium oxalate ticks the crown twice here. It's both the most common cause of renal stones and the most common type of kidney stone outright. And this brilliantly illustrates how clinical context is just everything. Let's say you have a patient with hypercalcemia. If they're in an outpatient setting, the most common cause is primary hyperparathyroidism. But if you see that exact same finding in a hospitalized patient, the answer totally flips to malignancy. The physical setting alone completely shifts your most likely diagnosis. So context matters just as much as the lab values. Okay, let's group some of these other distinct physical associations. For orthopedics, non-traumatic avascular necrosis of the femoral head is caused by corticosteroids. And what about a posterior hip dislocation? That's classically a dashboard injury from a motor vehicle accident. Moving to GU, the primary predisposition for testicular torsion is the aptly, if somewhat aggressively named, bell clapper deformity. Meanwhile, a hydrocele in adults is overwhelmingly idiopathic. Finally, for endocrine, make sure you explicitly connect secondary hyperparathyroidism to chronic kidney disease, whereas primary hyperparathyroidism is caused by a parathyroid adenoma. To wrap up our causes block, look at these vascular and general surgery stalwarts. The most common cause of an incisional hernia is, pretty predictably, previous abdominal surgery. A chronic leg ulcer is most frequently due to venous insufficiency. But pay really close attention to mesenteric ischemia and abdominal aortic aneurysms. Atherosclerosis is the common enemy here. It is absolutely the most common cause for both of them. All right, Section 3, surgical microbiology, and the most common organisms. The whole key here is matching the exact organism to its classic clinical scenario. Welcome to the absolute domain of E. coli. If you're dealing with an intra-abdominal or biliary infection, E. coli is more than likely driving the bus. Think acute cholecystitis, ascending cholangitis, pyogenic liver abscess, catheter-associated UTIs, and peritonitis. Those are all primary targets for E. coli. But, quick caveat, for acute appendicitis, while E. coli is definitely there, you absolutely must include Bacteroides fragilis too. That specific pairing is a hugely high-yield exam favorite. Now, let's group the gram-positive heavy hitters together. Staphylococcus aureus is your chief culprit for surgical site infections, acute osteomyelitis, and septic arthritis. But the second you introduce a prosthesis into the mix, like a prosthetic joint infection, you've got to cleanly separate your thinking and choose Staphylococcus epidermidis. Finally, for necrotizing fasciitis, you're looking at Group A Streptococcus, though keep in mind that one is very often polymicrobial in nature. Let's quickly contrast some of these more specific associations. Gas gangrene, Clostridium perfringens. Cetomembranous colitis is Clostridioides difficile. Osteomyelitis and sickle cell disease, that is a super specific association with salmonella. And an animal bite infection points straight to Pasteurella multocida. Now contrast those highly specific bugs against the aggressively polymicrobial nature of Fournier gangrene and diabetic foot infections. For those two, you aren't just fighting one bug, you're fighting a whole mixed colony. Which brings us to Section 4, most common risk factors. Knowing the underlying risk factor that sets the stage, that is next-level surgical mastery. So the crucial point to grasp here is just how much absolute systemic damage is caused by one singular habit. Smoking is the primary risk factor, connecting incredibly diverse vascular, urological, and GI conditions. It drives abdominal aortic aneurysms and peripheral arterial disease. It's the primary risk factor for pancreatic carcinoma and bladder carcinoma. And when you combine it with alcohol, it becomes a primary risk factor for chronic pancreatitis. Let's move to a timeline and see how this builds, tracking the temporal journey of a surgical patient. A patient's history directly dictates their future complications. On day 0, pre-op, a history of diabetes mellitus sets them up for a surgical site infection. Day 1, intra-op, poor nutrition or malnutrition drastically increases the risk of an anastomotic leak. By day 3, post-op, bed rest and immobility lead directly to DVTs and pressure ulcers. And months later, a previous wound infection is the glaring risk factor for an incisional hernia. The history always tells you the future. Okay, let's walk through this classic pathogenic sequence. This is a direct, step-by-step disease progression that you just have to know cold. It starts at step 1 with chronic GERD. This constant acid exposure acts as the risk factor, mutating the tissue into step 2, Barrett's esophagus. Once you have Barrett's esophagus, well, that becomes the primary risk factor for step 3, the development of esophageal adenocarcinoma. Step 1 leads to 2, 2 leads to 3. It's simple, it's deadly, and it's highly testable. Let's fire off some major oncology associations. We are matching highly specific genetic or environmental risk factors cleanly to their respective cancers. Hepatocellular carcinoma, hepatitis B infection. Cholangiocarcinoma, primary sclerosing cholangitis. Colon carcinoma, look out for familial adenomatous polyposis or Lynch syndrome. Thyroid cancer is deeply linked to previous radiation exposure. And for breast carcinoma, the major risk factors are increasing age combined with a family history. Now, I really want to point out a critical distinction here regarding skin cancers and ultraviolet light. Notice how basal cell carcinoma and squamous cell carcinoma of the skin share the exact same risk profile, chronic UV exposure, right? It's the daily, persistent sun damage over years. But contrast that with melanoma. The key risk factor there is intermittent, intense UV exposure. Think of those severe, blistering sunburns you might get on vacation. Catching that little nuance is exactly what separates good test takers from great ones. All right, here's our final barrage of facts for the risk factor block. A history of gallstones is the primary risk factor for gallbladder carcinoma. For peptic ulcer disease, make sure you highlight the synergistic risks of H. pylori infection combined with NSAIDs. Acute pancreatitis risk factors are predominantly gallstones and alcohol use. And finally, the major risk factor for osteoporosis after menopause is estrogen deficiency. Section 1. Most common nerve injuries. Let's think about the anatomy here, working our way from top to bottom. It's kind of like a map. Up at the shoulder, both a surgical neck of the humerus fracture and an anterior dislocation directly threaten the axillary nerve. Moving down the humerus, a midshaft fracture wraps around and risks the radial nerve. At the elbow, a supracondylar humerus fracture snags the median nerve. Specifically, you want to remember its anterior interosseous branch. Meanwhile, a medial epicondyle fracture hits the ulnar nerve right in its groove. Down at the wrist, lacerations commonly catch the median nerve. Now for the lower limbs, just memorize these two major ones. A fibular neck fracture compromises the common peroneal nerve, and a posterior hip dislocation threatens the massive sciatic nerve. Now, in the OR, the procedure itself can actually set the trap. In ortho, a total hip replacement puts the sciatic nerve at risk. Endocrine neck surgeries, well, they're absolute minefields. A standard thyroidectomy endangers the recurrent laryngeal nerve. But, and this is a big but, if you're ligating the superior pole, you actually risk the external branch of the superior laryngeal nerve instead. For lymph node clearances in the axilla, you've got to watch out for the long thoracic and thoracodorsal nerves. Moving to the head and neck, radical neck dissections threaten the spinal accessory. Carotid surgeries put the hypoglossal right in the crosshairs, and peritidectomies famously risk the facial nerve. Finally, in general and urologic surgery, Inguinal hernia repairs can catch the ilioinguinal or the genital branch of the genital femoral nerve. And a TURP procedure? That can actually stimulate the obturator nerve, which causes a sudden and very surprising adductor spasm. Moving on to Section 2, Clinical Features of Nerves. When you're evaluating these injuries, you've really got to visualize the physical deficit. An axillary nerve hit means a loss of shoulder abduction, plus that classic regimental badge numbness right on the lateral shoulder. Radial nerve damage, that causes a limp wrist drop. A median nerve injury actually flattens at the inner eminence into what we call an ape thumb and completely steals thumb opposition. An ulnar nerve injury leaves a patient with a claw hand. And downstairs, a common perineal nerve injury results in a slapping foot drop. Looking specifically at the upper body, these physical signs are absolutely pathognomonic. If you see a winged scapula pushing out of the back, that is the long thoracic nerve, no question. A shoulder droop? Spinal accessory. If your post-op neck surgery patient is suddenly hoarse, you've likely hit the recurrent laryngeal nerve. But if they just can't hit those high pitches anymore when they speak or sing, that points strictly to the external laryngeal nerve. Okay, so having mastered the nerves, let's pivot for a second to oncology and ask ourselves this: what are the absolute most common surgical tumors we're going to counter? That brings us to Section 3, the most common tumors. You really want to pay attention to the contrast between benign and malignant here. For instance, in the salivary glands, the most common benign tumor is a pleomorphic adenoma, but the most common malignant one is a mucoepithermoid carcinoma. For the breast, the most common benign mass overall is a fibroadenoma. Down in the liver, the most frequent benign finding is a cavernous hemangioma, whereas the most common primary malignancy is hepatocellular carcinoma. And hey, don't forget the appendix. Its most common tumor is a neuroendocrine tumor, which was historically known as a carcinoid. Continuing our rapid-fire review, papillary carcinoma heavily dominates the thyroid. Out on the skin, basal cell carcinoma is king. Specifically, you'll see the nodular subtype most often. Inside the oral cavity, squamous cell carcinoma is pretty much the standard. Moving lower, renal cell carcinoma is the most common renal tumor. Germ cell tumors are the primary concern in the testicles, and if a soft tissue sarcoma pops up, liposarcoma goes right to the top of your differential. Let's move to a super crucial anatomical distinction in the GI tract. Worldwide, the most common esophageal cancer is squamous cell carcinoma. But, and this is key, if you look at the lower third of the esophagus, as well as the most common gastric cancer and the most common colorectal cancer, in all of those locations, adenocarcinoma takes the crown. This perfectly reflects the transition of the mucosal lining from squamous to glandular tissue. Section 4, high-yield tumor sites. Location is everything right. It often just gives away the diagnosis entirely. Basal cell carcinoma loves the face, specifically targeting the nose and the nasolabial fold. Squamous cell carcinoma of the skin prefers sun-exposed areas. Inside the mouth, oral SCC classically sits right on the lateral border of the tongue. In the GI tract, esophageal SCC prefers the middle third, whereas esophageal adenocarcinoma hits the lower third. Finally, colorectal carcinomas very frequently cluster down in the rectosigmoid region. Now, you need to carefully contrast these specific presentations. A gastric ulcer carcinoma classically hides on the lesser curvature of the stomach, whereas a benign peptic ulcer perforation typically punches right through the anterior first part of the duodenum. Down on the leg, a venous also favors the medial malleolus. And note this really fascinating gender divide for melanoma. It preferentially appears on the lower limbs in females, but primarily on the trunk and back in males. For bone tumors, the best trick is to anchor your memory to the long bone anatomy around the knee. Osteosarcoma hits the metaphysis. A giant cell tumor strikes the epiphysis, right at the very end of the bone. Meanwhile, Ewing sarcoma targets the diaphysis, or the main shaft of the bone. Section 1. Most common surgical complications. Because in surgery, knowing exactly what can go wrong is just as important as knowing how to operate. All right, starting with the GI tract, you absolutely need to lock in these associations. Acute appendicitis, think perforation. Acute pancreatitis, pancreatic pseudocysts. But notice the shift where we talk about chronic pancreatitis. The most common complication there actually becomes diabetes mellitus because that endocrine tissue is just progressively destroyed over time. Now, for acute cholecystitis, you're watching for empyema or perforation. Down in the lower GI tract, diverticulitis loves to form abscesses. Crohn's disease, because of its transmural nature, is notorious for fistula formation. And ulcerative colitis, that carries the dreaded, highly tested risk of colorectal carcinoma. These are pure high-yield gold. Moving north to the head, neck, and then down to urology. If your patient just had a thyroidectomy, you're instantly on alert for hypocalcemia and recurrent laryngeal nerve injury. A splenectomy carries a pretty serious dual threat: overwhelming post-splenectomy infection, or OPSI, and reactive thrombocytosis. Over in urology, beware of TERP syndrome, where absorbing all that irrigation fluid leads to severe hyponatremia. With tracheostomies, it's all about timing. Early on, you're worried about bleeding, but late in the game, watch for tracheal stenosis. Finally, paroidectomies risk facial nerve injury, and a carotid endarterectomy can leave you dealing with a massive, airway-compromising neck hematoma. So, in orthopedics and hernias, the underlying anatomy really dictates the risk. A Colles fracture is going to directly compress that median nerve, while the retrograde blood supply of the scaphoid makes it incredibly susceptible to a vascular necrosis of the proximal pole. For hernias, remember that femoral hernias have a really high rate of strangulation, whereas inguinal hernias often present with incarceration. Also, notice how a seroma is the shared complication for both a mastectomy with axillary clearance and a ventral hernia repair. And look, whenever you're dealing with bowel surgery or an esophagectomy, an anastomotic leak is your #1 enemy, just like a paralytic ileus is for a laparotomy. Section 2, the post-operative fever timeline. This is an absolute classic. If you ever step foot on a surgical floor, I guarantee this will come up. Let's map out the classic 5 Ws of post-op fever sequentially. Day 1 is wind, meaning atelectasis. By day 3, we move deeper into the lungs for pneumonia. Day 5 is water, so you're hunting for urinary tract infection. Day 7 is wound. That's your classic window for a surgical site infection to actually manifest. And what if they spike a fever after day 7? Well, think walking. Suspected DVT, a pulmonary embolism, or a deep interabdominal collection. Definitely lock this timeline into your brain. Section 3, Investigations of Choice, or IOCs. This section demands rapid-fire recall of the absolute best first move for any given scenario. What's really fascinating here is how the imaging for appendicitis shifts entirely based on the patient demographic. Adults get a contrast-enhanced CT of the abdomen, right? But for kids, we obviously want to avoid radiation, so the IOC is an abdominal ultrasound. Pregnant patients also start with an ultrasound, keeping an MRI in your back pocket as a backup. For the biliary tree, acute cholecystitis starts with an ultrasound, but if you're suspecting stones lodged in the common bile duct, choledocholithiasis, you've got to order an MRCP. Acute mesenteric ischemia demands CT angiography, and a complex fistula ano needs an MRI of the pelvis to properly map out those tracts. For the upper GI tract, whether it's esophageal carcinoma, gastric carcinoma, or Barrett's esophagus, upper GI endoscopy with a biopsy is king. You need that direct visualization and tissue sampling. For any kind of neck or thyroid swelling, your very first move is a neck ultrasound. If that ultrasound turns up a suspicious thyroid nodule, you follow it up with an FNAC. Now, for a generic breast lump, you do the classic triple assessment, which is clinical exam, imaging, and pathology. But if you specifically need a tissue diagnosis of a breast mass, you rely heavily on a targeted core, or TrueCut biopsy. Urology and trauma are where examiners really love to test your precision. You can't just throw out CT as a guess for everything here. A renal stone needs a non-contrast CT KUB. But if the patient has stable renal trauma, or you're staging renal cell carcinoma, you have to switch to a contrast-enhanced CT. For lower tract trauma, making the right distinction is critical. Bladder injury, that's CT cystography, but a urethral injury, you absolutely must use a retrograde urethrogram. Whatever you do, never blindly insert a catheter, or you'll literally make the tear worse. Oh, and for pelvic-uraric junction obstruction, or PUJO, the MAG-3 renogram is your go-to test. To round out our IOCs, let's look at vascular and ortho. Vascular workup logically leans on sound waves. You're deploying a venous Doppler ultrasound for DVT, a duplex arterial Doppler for peripheral arterial disease, and a standard abdominal ultrasound for AAA screening. Moving into ortho, a swollen red joint where you suspect septic arthritis, that requires immediate joint aspiration. Meanwhile, almost all the major structural bone and joint injuries, things like osteomyelitis, avascular necrosis, ACL tears, and rotator cuff tears, they all demand an MRI so you can actually see the soft tissue. Lastly, carpal tunnel syndrome is evaluated best using nerve conduction studies. Section 4, Gold Standard Investigations. Remember, the investigation of choice is your best initial step, but the gold standard is what gives you 100% diagnostic certainty. So sometimes your investigation of choice is actually the definitive gold standard too. We see this with nerve conduction studies for carpal tunnel and CT angio for acute mesenteric ischemia. but pay close attention to the shifts. For acute appendicitis, yeah, your first move is a contrast CT, but the definitive, gold standard confirmation ultimately requires histopathology of the removed appendix. Knowing the exact difference between what you order first and what definitively confirms the disease is exactly how you ace these exam questions. For these systemic and GI conditions, you've just got to memorize the definitive tests. Esophageal carcinoma and Barrett's esophagus rely on endoscopy with biopsy. For severe GERD, the gold standard is 24-hour pH monitoring. If a pheochromocytoma is on your radar, look for plasma-free metanephrines. Those are the breakdown products of all those excess hormones. In peds and GI, Hirschsprung disease requires a rectal biopsy to explicitly prove there are no ganglion cells, and celiac disease needs a duodenal biopsy. And if you're prepping for surgery and trying to definitively localize hyperparathyroidism, the sestamibi scan is your gold standard. When it comes down to tissue and joint fluid diagnosis, grabbing the exact right sample is critical. The gold standard for breast carcinoma is a core needle biopsy. But listen, remember that melanoma specifically demands an excision biopsy. You want to take the whole entire lesion out with clear margins, not just poke at it. Finally, while you definitely aspirate a joint initially for septic arthritis, the fundamental gold standard for locking in that diagnosis is the actual joint fluid culture. Section 5. Key classification systems. Examiners absolutely love these because they prove you actually know how to stratify risk and guide real clinical management. Let's rapidly link the condition to its scoring tool. Appendicitis gets the Alvarado score. Assessing pancreatitis severity, you're using the Ransom criteria, or the BISAP score. Child-Pugh is your absolute baseline for categorizing liver disease severity, while the Glasgow-Blatchford score predicts the risk level of an upper GI bleed. And when you're looking at a CT scan trying to gauge diverticulitis severity to decide between antibiotics or surgery, you'll use the Hinchey classification. Finally, let's cement these trauma and specific scoring systems. Head injuries universally use the Glasgow Coma Scale. It's literally the language of trauma based everywhere. Open fractures get the Castillo-Anderson classification. Hip fractures use the Garden classification to predict avascular necrosis risk. Over in urology, the Bosniak classification is essential for evaluating renal cysts for malignancy. Skin cancer differentiation relies on the Broders classification, and of course, for burn severity, we use the total body surface area, or TBSA calculation. Kicking things right off with Section 1, fluids, electrolytes, and acid base. Let's use some one-line recalls to instantly trigger your memory. If a patient has persistent vomiting or a gastric outlet obstruction, bam, think hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Diarrhea, that brings metabolic acidosis. But a high-output ileostomy, that's going to cause hypokalemia plus dehydration. If you're dealing with a pancreatic fistula, expect metabolic acidosis right alongside fluid and electrolyte loss. Now, acute pancreatitis, that triggers hypocalcemia, specifically due to fat saponification. And don't forget, TERP syndrome causes dilutional hyponatremia. Refeeding syndrome drops your phosphate, potassium, and magnesium. Moving on, link primary hyperparathyroidism directly to hypercalcemia and chronic kidney disease to secondary hyperparathyroidism. Finally, absolutely memorize the massive blood transfusion triad: hypocalcemia, hypothermia, and coagulopathy. Look at how strictly common clinical conditions correlate with their acid-base counterparts. Fluid loss from vomiting literally pulls acid out of the body, leaving you with metabolic alkalosis, right? While diarrhea dumps space, leaving metabolic acidosis. Note the nuances here. Sepsis and shock give you a very specific lactic metabolic acidosis. Meanwhile, diabetic ketoacidosis, or DKA, presents as a high anion gap metabolic acidosis. Breathing issues follow the exact same logic. COPD traps air, causing respiratory acidosis, while blowing off too much CO2 during anxiety or hyperventilation flips you straight into respiratory alkalosis. All right, moving right along to Section 2, Radiology, Signs, and Neurosurgery. Consider this your ultimate cheat sheet for classic board-style imaging signs. Ewing sarcoma presents with that classic onion skin periosteal reaction. Osteosarcoma, that boosts the sunburst appearance, and Codman's triangle. A giant cell tumor is going to show a soap bubble appearance. Moving down to the gut. Intussusception gives a target or coiled spring sign. A sigmoid volvulus shows a coffee bean sign, while achalasia cardia reveals a bird beak appearance. Colorectal carcinoma classically narrows into an apple core lesion. Crohn's disease shows a string sign, and gallstone ileus presents with a wriggler triad. Finally, free air under the diaphragm, that is your massive red flag for pneumoperitoneum. Now, bridging into neurosurgery, we've got a classic face-off. The crucial point here is the visual distinction between head traumas.
Subdural hematomas originate from torn bridging veins, and they bleed into a distinct crescent-shaped hyperdensity on a scan. On the flip side, an epidural hematoma is usually an arterial bleed from the middle meningeal artery, and that forces the blood into a tense, lens-shaped or biconvex hyperdensity.
Listen, if those bleeds expand, you're going to see this. You absolutely must treat this high-yield definition like a flashing red light on the ward. The Cushing response, which is hypertension, bradycardia, and irregular respiration, is basically your patient's body screaming that they have dangerously raised intracranial pressure. Recognizing this triad instantly can literally save a patient from impending brain herniation. Sticking with neurosurgery, keep in mind that way before you ever see a Cushing response, the very initial sign of raised ICP is always an altered level of consciousness. And speaking of consciousness, if you assess a Glasgow Coma scale of 8 or less, you intubate immediately to protect that airway. We also have the classic sudden worst headache of life, which should immediately scream subarachnoid hemorrhage, or SAH. On imaging, you're going to see blood filling the basal cisterns, which is most commonly caused by a ruptured berry aneurysm. By grouping these lobe lesions and pituitary tumors together, it's kind of like mapping out real estate. A tumor's physical location dictates its specific deficits. Frontal lobe lesions alter personality and motor function. Parietal lesions lead to loss of sensation or neglect, and occipital lesions cause visual field defects. In the pituitary region, a macroadenoma causes bitemporal hemianopia. A prolactinoma presents with galacturia and amenorrhea. A growth hormone-secreting adenoma leads to acromegaly. And finally, if a child presents with visual defects and endocrine problems, always suspect a cranial pharyngioma. Let's keep the momentum going with Section 3, Vascular and Orthopedic Surgery. Notice a pattern here? We rely heavily on ultrasound and duplex modalities in vascular surgery. Whether we're screening an abdominal aortic aneurysm, investigating varicose veins with a venous duplex, or assessing carotid stenosis with a duplex Doppler, sound waves are totally our best friend here. Also, lock in these clinical profiles. An acute limb ischemia is characterized by the classic 6 Ps. A ruptured AAA mandates either an emergency laparotomy or an endovascular aneurysm repair, known as EVAR, purely depending on patient stability. And Berger disease is classically going to show up in a young patient who smokes. This is pure, rapid pattern recognition. Just knowing the location and morphology can instantly differentiate your ulcers. An ulcer situated right over the medial malleolus, that's a venous ulcer. But if it's located distally on the foot or toes with a distinct punched-out appearance, that is an arterial ulcer. Time for some ortho high yields. Commit these rapid-fire physical exam associations to memory. A positive Lachman test means an ACL injury, just as a positive posterior jaw test points straight to the posterior cruciate ligament. For upper extremities, shoulder dislocations are most commonly anterior. A Colles fracture gives you that famous dinner fork deformity, and a scaphoid fracture will present with pinpoint snuffbox tenderness. But most critically, exquisite severe pain on passive stretch, that is your absolute red flag for compartment syndrome. Now, complications are heavily tested for sure, so immediately link that scaphoid fracture we just talked about directly to its most feared complication, avascular necrosis, or AVN. For infections, the primary culprit for osteomyelitis is Staphylococcus aureus, and the definitive treatment for septic arthritis is a prompt arthroscopic washout. Finally, if you even suspect AVN of the femoral head, remember that an MRI is your definitive imaging investigation of choice. Moving right into Section 4, Urology and Perioperative Management. The absolute key here is matching the specific anatomical level of a stone or obstruction straight to its procedural fix. A pelviureteric junction obstruction, or PJO, requires a MAG-3 renogram. If you've got a massive renal stone greater than 2 centimeters, you jump to a percutaneous nephrolithotomy, or PCNL. A lower ureteric stone? That just requires ureteroscopy. And here's a great clinical pearl. A bladder stone in an elderly male strongly implies an underlying bladder outlet obstruction holding that urine up. In urology, time is tissue. Always remember that testicular torsion is a massive race against the clock, requiring surgical exploration within hours. Whereas a retractile testis, that simply needs careful observation and follow-up. An undescended testis, however, will require an orchidopexy. Furthermore, the very first investigation for male infertility is always a semen analysis. Lastly, if you face a ureteric injury after pelvic surgery, management involves ureteric reimplantation or repair, which heavily depends on the specific site of the injury. I love mapping these facts out chronologically because it creates a foolproof mental timeline for perioperative safety. Check this out. At -5 days before elective surgery, you stop warfarin, bridging them if they're at high thrombotic risk. Right before surgery, ensure the platelet count is greater than 50,000 per microliter. And if you need blood, remember packed RBCs are stored precisely at 2 to 6 degrees Celsius. At exactly -60 minutes before the incision, you administer antibiotic prophylaxis. And post-operatively, if there's a needle injury, your HPV protocol depends strictly on the worker's vaccination status and anti-HBs titer. Finally, we're bringing it home with Section 5, Important Scores and Classifications. All right, let's unpack this final high-yield box. In medicine, we absolutely love our eponyms, and you must know exactly what each one classifies. Pre-op fitness, that's your ASA classification. Need to assess a difficult airway? That's the Mallampati score. Liver disease is split into the Child-Pug score for chronic severity and the MELD score for transplant priority. Match Hinchey specifically to diverticulitis, Castillo-Anderson to open fractures, and the Garden classification to neck of femur fractures. Finally, TNM is your universal cancer staging. Broders looks at squamous cell carcinoma differentiation, and the Bosniak classification tells you everything you need to know about renal cysts.
All right, let's jump straight into part 1, emergency initial management.
In the trauma bay, seconds literally save lives, and it always starts with the ABCs. If your patient has a compromised airway or a Glasgow coma scale of 8 or less, you are going straight for endotracheal intubation. Got a burn patient with a suspected airway injury? Early intubation is your mandate, right away, before that tissue swells up and closes the airway completely. But notice the nuance here. If you're dealing with severe facial trauma obstructing the airway, your primary goal is just to secure that airway first and foremost by whatever means necessary. Now, moving down to the chest. The sheer pressure of a tension pneumothorax means you need immediate needle decompression. You don't have time to wait. That's totally different from an open pneumothorax, where you need a 3-sided occlusive dressing to act as a one-way valve, or a massive hemothorax, where an intercostal chest drain is required to clear all that pooled blood.
Whether we're talking about the heart or a limb, the absolute primary goal here is restoring perfusion. Unstable cardiac tamponade, pericardiocentesis is your immediate go-to. What about a suspected ruptured AAA? That is a one-way ticket straight to emergency vascular surgery. On the limb-threatening side of things, if you see a knee dislocation and can't find a distal pulse, you need immediate vascular assessment and repair. If the pressure is building up and you've got acute compartment syndrome, you have to relieve it immediately with an emergency fasciotomy. And for acute limb ischemia, you're hitting them fast with IV heparin to stop any further clotting.
Moving down the body, let's look at urological and pelvic emergencies. Acute urinary retention? Pretty straightforward, to get a urethral catheter. But pay close attention to this next point because it's absolutely crucial. If you even suspect a urethral injury, you must stop and do a retrograde urethrogram before you ever attempt to place a catheter. It's a classic pitfall. Next up, if paraphimosis fails manual reduction, you do a dorsal slit to quickly relieve that constricting band. Testicular torsion means immediate surgical exploration to save the testicle. And for pelvic fractures, your intervention matches the threat level. If the pelvis is unstable, you throw on a pelvic binder. But if there's ongoing bleeding, you're escalating to angioembolization or pelvic packing to gain control.
Let's wrap up our emergency triage by talking about infectious and orthopedic emergencies. The defining feature here? Aggression. You cannot wait on these. Necrotizing fasciitis requires urgent, aggressive surgical debridement paired with heavy, broad-spectrum antibiotics. Its perineal equivalent, Fournier gangrene, demands the exact same emergency debridement. For an open fracture, you're starting IV antibiotics immediately, along with an urgent washout and debridement. And if a patient has septic arthritis, you need joint aspiration combined with IV antibiotics to protect that joint space before irreversible damage occurs.
Moving right along to Section 2, Trauma Patient Protocols.
So how does this actually flow in practice? Step 1 for literally any trauma patient is your ATLS primary survey, the classic ABCDs. That sets the stage. From there, it's a logical decision tree. Step 2, if their GCS is 7, that naturally triggers intubation. Because remember, a score of 8 or less means they simply cannot protect their own airway. Step 3, if your trauma patient presents in shock, you have a dual mandate. You have to aggressively control the hemorrhage while simultaneously starting blood resuscitation.
Now this is one of my favorite high-yield clinical distinctions. Picture 2 chest trauma patients. Both of them have absent breath sounds on one side. But just one simple physical finding completely changes your diagnosis and your next move.
If you percuss the chest and hear hyperresonance, you've got a tension pneumothorax on your hands. Air is trapped. But if you percuss and hear dullness, that's a hemothorax. Blood has pooled in the cavity. It's one subtle finding leading to two entirely different, rapid, life-saving interventions.
Let's look at how we manage some other major trauma presentations. A flailed chest needs solid analgesia, oxygen, and ventilatory support if they're struggling. We just talked about this, but it is so important it bears repeating. If you see signs of a urethral injury, like blood at the meatus, do a retrograde urethrogram before you even touch a catheter. If you suspect a bladder rupture, order a CT cystography. And finally, let's contrast blunt abdominal trauma. If the patient is hemodynamically stable, you can safely get a contrast-enhanced CT of the abdomen. But if they're unstable, you bypass the CT scanner entirely. Unstable means a direct, immediate trip to the operating room for an emergency laparotomy. No exceptions.
All right, taking a breath, we're into Section 3, Definitive Treatments for GI and General Surgery.
As we shift from emergency stabilization to definitive care, notice how the timing and the specific condition dictate our surgical approach. Take the appendix. Simple acute appendicitis, straightforward appendectomy. But if it's perforated, you start with antibiotics first, and the timing of the surgery depends entirely on how they respond. In the biliary system, symptomatic gallstones get a standard laparoscopic cholecystectomy, while acute cholecystitis warrants an early lap chole. If a stone is lodged in the common bile duct, choledocholithiosis, you need to go in with an ERCP and sphincterotomy. For the pancreas, chronic pancreatitis with an obstruction needs a drainage procedure, but if you have a symptomatic pancreatic pseudocyst that's been hanging around for more than 6 weeks, that calls for an endoscopic cystogastrostomy.
Check out the clear escalation of interventions for anorectal conditions here. A chronic fissure gets a lateral internal sphincterotomy. But look at the fistulas. A simple one just needs a quick fistulotomy. If it's a complex fistula, though, you have to be careful and do a Seriton placement to manage it safely over time. A pilonidal sinus requires excision. For hernias, whether femoral or inguinal, they require their respective surgical repairs. And if you're dealing with a hydatid cyst of the liver, you're looking at surgical excision, but really only in carefully selected cases.
Section 4, Definitive Treatments for Uro and Endo.
Let's translate some common urological presentations into their definitive fixes. Renal cell carcinoma requires a partial or radical nephrectomy. Got a massive renal stone over 2 centimeters? That needs a PCNL. But a stone lower down in the ureter is treated with ureteroscopy and lithotripsy. A pelvio-ureteric junction obstruction, or PUJO, gets fixed with a pyeloplasty. Now, remember our emergency testicular torsion from earlier? The definitive long-term fix is a bilateral orchidopexy to anchor things down and make sure it never happens again. A varicocele causing infertility gets a varicocelectomy. Obstruction from BPH is cleared out with a TURP. And for localized prostate cancer, your major definitive paths are radical prostatectomy or radiotherapy.
When we're talking about oncology and vascular surgery, definitive care is really all about permanent tumor control and mechanical solutions. Colon cancer? That means oncological resection with lymphadenectomy. Resectable esophageal cancer mandates an esophagectomy. For the endocrine system, a thyroid malignancy gets a thyroidectomy, and a parathyroid adenoma is cured with a parathyroidectomy. On the vascular side, if you have symptomatic carotid stenosis, you mechanically clear it out with a carotid endarterectomy. And a carotid body tumor? That simply requires complete surgical excision.
Almost there! Section 5, Wound Management.
There's a very logical progression to how we handle wound closure, and it's all based on infection control. If a wound is clean, great, you do an immediate primary closure. But if it's contaminated or already infected, you use delayed primary closure to give the tissue time to clear. Taking it a step further, if you have a wide open, actively infected wound, you leave it completely open. You want it to heal from the bottom up, healing by secondary intention. You never want to seal an infection inside by closing it up too early. The same logic applies to a carbuncle. You incise it, drain it, and leave it to heal by secondary intention.
Now, even with textbook technique, complications happen. If a wound pulls apart and you get dehiscence, you start with supportive management, stepping in with surgical repair only if it's really required. But let's look at how we treat problematic scars long-term. A keloid grows aggressively past its original boundary, so we treat it with an intralesional triamcinolone injection. A hypertrophic scar, on the other hand, stays within its borders but gets thick and raised. We manage that with a steroid injection plus pressure therapy to physically flatten it out.
Finally, Section 6, Burn Assessment and Treatment.
This basic algorithm is the backbone of thermal burn management. Step 1 is obvious but critical.
Stop the burning process and get cool running water on it. But step 2 is where the vital math comes into play. Fluid resuscitation using the Parkland formula. Burn patients lose massive amounts of fluid, and managing that fluid shift is the absolute critical bridge between the initial injury and getting them to the OR. In step 3, if they have a circumferential limb burn, you do an escharotomy to save the limb from acting like a tourniquet. And if it's a full thickness burn, you are headed straight for surgical excision and skin grafting.
We also have to carve out a massive exception for electrical burns. The tiny surface wound you see from an electrical strike tells you literally nothing about what's happening underneath. Electricity cooks from the inside out. You have to aggressively assess for hidden deep tissue damage and keep a very close eye out for severe cardiac complications like fatal arrhythmias.
Starting with Department 1, Breast and Endocrine Pathology. We are hunting for specific diagnostic red flags here.
Take a look at this timeline. Patient demographics instantly anchor your differential, right? Picture this. If you see a young female patient presenting with a breast lump, your brain should immediately jump to a fibroadenoma. It's the absolute most common benign breast tumor in this age group. Now, shift your mental picture to a patient between the ages of 50 and 70. This is the peak age group for breast cancer risk. But wait, we also have to consider male patients. If a male presents with breast cancer at literally any age, the major risk factor you need to associate with that is a BRCA2 mutation. Try to visualize those 3 distinct patients, because age and gender are going to guide your very first diagnostic step. Let's rapidly fire off some non-negotiable associations. When breast cancer spreads, the most common lymphatic spread is to the axillary lymph nodes. Next up, and guys, this is a massive clinical pearl you just cannot miss. If you see Paget disease of the nipple, you have got to treat it as an underlying breast carcinoma until proven otherwise. It's a flashing red light. Moving on, what drives gynecomastia? It's an increased estrogen to androgen ratio. And finally, if you diagnose a Phyllo's tumor, the surgical treatment association you need to lock in is a wide local excision. Let's see how this builds into the endocrine system. We've got a high-yield table of pearls here. First off, the most common cause of hyperthyroidism, Graves' disease. Now, pay super close attention to the binary difference between thyroid nodules here. A hot thyroid nodule is usually benign, but a cold thyroid nodule, that carries a higher malignancy risk. You've got to keep that hot versus cold distinction crystal clear. If a patient escalates into a thyroid storm, your immediate medical association is a beta blocker plus antithyroid medication. And lastly, for primary hyperparathyroidism, always look for the classic presentation vignette, stones, bones, groans. Sticking with endocrine for just a second, we have to talk about multiple endocrine neoplasia. Honestly, comparing these 2 syndromes side by side visually like this is the absolute best way to memorize them. MEN1 is associated with parathyroid, pituitary, and pancreatic tumors. Contrast that directly with MEN2, which is uniquely associated with medullary thyroid carcinoma and pheochromocytoma. Lock in that contrast between MEN1 and MEN2 right now. Okay, moving on to Department 2, Hepatobiliary and Pancreatic Conditions. Keep your energy up, we are moving fast. Here are your ironclad hepatobiliary rules. First, the most common type of gallstone is a cholesterol stone. Simple enough. Next, I want you to picture a patient already in the ICU. Acute acalculous cholecystitis typically strikes critically ill patients. Now picture an elderly patient presenting with signs of a bowel obstruction. Your brain should immediately consider a gallstone ILS. So what about biliary colic? The physiological cause there is a transient cystic duct obstruction. And if you're looking at cholangiocarcinoma, the most common site is the perihilar region, which is known as a Kletskin tumor. Now watch how a severe biliary infection cascades. Step 1 is the classic Charcot triad. But watch what happens in step 2. If you add hypotension, and then in step 3 you add confusion, well, you have just escalated straight into Reynolds pentad. This step-by-step flowchart is a great way to visually demonstrate a patient crashing into systemic shock. Let's slide over to the pancreas. I highly recommend screenshotting this high-yield box for your board prep. The most common pancreatic endocrine tumor is an insulinoma, and its presentation is inextricably linked to the Whipple triad. Next, a VIPnoma presents with a very specific trio of symptoms: watery diarrhea, hypokalemia, and achlorhydria. For a gastronoma, you just need to memorize its location, the pancreas or the duodenum. And in cases of pancreatic trauma, if there's a tail injury, the procedural association you need is a distal pancreatectomy. Awesome. Department 3, Stomach and Colorectal Disorders. Let's keep that rapid-fire diagnostic mindset fully engaged. Notice how interconnected these stomach pathologies are? H. pylori infection is a major double threat. It's a risk factor for both gastric carcinoma and it's associated with gastric lymphoma. Next, what's the most common cause of a gastric perforation? Peptic ulcer disease. And if you ever see the term linitis plastica, lock that in immediately with diffuse gastric carcinoma. Let's look at the esophagus and portal system. A patient with dysphagia and regurgitation? That points directly to a Zenker diverticulum. Now, the crucial point here is how this next sequence chains together. Esophageal varices are caused by portal hypertension. And what's the most common cause of portal hypertension? Cirrhosis. See how one pathology directly feeds into the next. Dropping down to the colorectal region, remembering that locating the pathology is basically half the diagnostic battle. The most common cause of intestinal obstruction in adults is adhesions. If we're talking about a volvulus, the most common site overall is the sigmoid colon. However, if it's a cecal volvulus specifically, it presents as a right lower abdomen obstruction. Moving to anorectal issues, an anal fistulous common cause is a cryptoglandular infection. A perianal abscess, the treatment is incision and drainage, and a pilonidal sinus is commonly cited at the needle cleft. You're doing outstanding work so far. Department 4, Urological and Genital Urinary Issues. We're hitting the final stretch of this ward round, so let's keep that focus razor sharp. I absolutely love this comparison because it emphasizes how patient age completely flips your differential for the exact same clinical presentation. If you have epididymal orchiditis in a young male, the most common cause is STI organisms. But if you see epididymal orchiditis in an elderly patient, the most common cause shifts entirely to urinary pathogens. It's the same symptoms, but completely different culprits, based purely on demographics. And this table brilliantly illustrates the chemical distinctions in uro-oncology. Look at the most common testicular tumor markers. A seminoma might have raised beta-HCG and LDH, but a non-seminomatous tumor will show both AFP and beta-HCG. For bladder cancer, the most common type is transitional cell carcinoma. If you're dealing with upper tract urothelial carcinoma, the anatomical locations you need to know are the renal pelvis and ureter. Finally, the major complication to anticipate with a neurogenic bladder is recurrent UTIs. Last stop, Department 5, Vascular and Orthopedic Trauma. We're in high-stakes territory now. These are vascular emergencies, where recognizing text-based associations instantly can literally be life-saving. The most common site of an abdominal aortic aneurysm, or AAA, is the infrarenal aorta. Paint a vivid picture of this next one in your mind. An AAA rupture presents with sudden abdominal or back pain paired with shock. You need to instantly recognize that. Carotid stenosis will present with TIA symptoms. Raynaud phenomenon is characterized by episodic digital ischemia. And Berger disease, that's synonymous with thromboangiitis obliterans. Wrapping up with orthopedics here, the most common fracture in the elderly is the neck of femur fracture. And you must know its severe complications, avascular necrosis or AVN, plus non-union. For shoulder dislocations, the anterior dislocation is the most common. And when you are assessing an ankle fracture, the critical standalone algorithm you have to rely on is the Ottawa ankle rolls. Lastly, we require absolute genetic precision for bone sarcomas. I just love the visual simplicity of having these two markers contrasted directly on screen like this. Osteosarcoma has a marker association with an RB1 mutation. Ewing sarcoma, on the other hand, is associated with the T1122 translocation. Short, sweet, and incredibly high yield. And just like that, our ward round is complete. We have synthesized a massive amount of data today by structuring it logically. Organizing facts visually like this guarantees better retention, and it's exactly what prepares you for the high-pressure environment of the real world. But before you go, let's test that active recall from earlier in our shift. If a patient presents with sudden dysphagia and regurgitation, what diverticulum should immediately come to mind? Hold on to that answer. Keep reviewing these structured associations and stay curious. See you next time on The Explainer.